You are live, ma'am.
Okay. Thank you so much. Good evening, everyone. So we are back again with DOS Super Tuesdays. On behalf of Delhi Ophthalmological Society, we welcome you all for today's session. And today we are going to discuss step-by-step guide to surgical process of penetrating keratoplasty. And we have with us, our speaker is Dr. Sushank Bhalerao, who is a cornea consultant in KVC campus, Vijayawada. And we have an expert panel, Dr. Rajesh Fogla sir, Dr. Bhupesh Singh, Dr. Sharon D'Souza, Dr. Shifali Mazumdar, Dr. Rajat Jain, Dr. Anu Malik, Dr. Pranita Sahai. And I'm Dr. Aditi Gosistar, your moderator. So let me speak a little bit about our speaker. Thank you for being a part of our DOS Super Tuesday, Dr. Sushank. So Dr. Sushank is presently working as consultant in Shantilal Shangvi Cornea Institute, KVC campus of LB Prasad Eye Institute, Vijayawada, Andhra Pradesh. And today he's going to tell us about the steps and tricks to penetrating keratoplasty. Without much delay, over to you, Dr. Sushank, and we will welcome you once again.
So good evening, everyone. Hopefully I'm audible and my slides are also visible.
Yes, you are audible and slides are visible. You can start.
So I'm Dr. Sushank, working as cornea consultant in LB Prasad Eye Institute, Vijayawada. And I'll be talking about a step-by-step guide to the surgical process of penetrating keratoplasty. I'll be talking about few protocols from our institute, what we follow here. There may be difference of opinion and I would love to learn from that from every one of you. So this is what our target is when we are doing an optical keratoplasty with such a clear, nice graft, properly radially arranged sutures and everything just clear. So this is what our target is and we are working towards this target on post-op day 1 or 1 week. So what I'm going to speak initially about practice keratoplasties, as most of the listeners are residents or who are learning cornea procedures. So hopefully this session will help you all. So this is just an outline of my presentation. Initially, I'll just speak few words about practice keratoplasties, followed by brief introduction, then pre-operative preparation, what we used to do, and goals or what are ideal suturing techniques, and surgery and suturing technique with some videos backing up all the discussion. So this is how when I did my practice keratoplasty, and this is all my mentors or my teachers who give me all their inputs. This is what we used to do at our institute. We used to practice 20 keratoplasties, and then for each keratoplasty we used to grade it according to radiality, depth, length, anterior chamber formation. And after that, everyone used to give some scores. So these are all, I don't mind showing my poor scores in initial few practice keratoplasties, but this is how we learn practice, or this is how we learn keratoplasties in initial days. So finally, I could achieve somehow near 7 or 8 from the great people of our institute, but still I'm working on it. So what we all need to do, we just need to do some friendship with each of our instruments, whatever we are using. We just have to be regular in our wet labs, despite our busy schedule in residency or wherever we are working in fellowships. So we just have to be there in wet labs. We have to practice sutures with both hands. All types of sutures we have to practice. And at the same time, nowadays, I'm telling our fellows to practice keratoplasties as practice penetrating keratoplasty, as well as initially they are making DMEC rolls. And then of remaining stroma, they are just doing practice keratoplasty. So in one tissue, we can just practice 2 surgeries in one go. So always and always don't hesitate to score yourself. Even though it is poor that I have done it very badly. Like in my first practice keratoplasty, I just shared with my colleague who is Dr. Prabhakar from AIMS. And he was so humble and my sutures were so poor. And I just showed him what is this. Then he showed, Bhaiya, it's like some sutures तो आपके तैर रहे हैं. आप बुरा मत मानिए लेकिन so this is how we have to ask our peers or maybe our teachers. And if they are grading you, then don't mind. We are in learning stage, and definitely we are going to learn on and achieve towards the goal. So also one more thing I noted, that morbidity meetings which we used to have with our consultant was very useful. What we do in morbidity meetings, we just take one surgical video, whoever did it, whether fellow or wherever it is, and if there are so many learning points from that video, just sit with some group of 4-5 people and discuss among yourself what better could be done, or what are the others' opinion when they are doing that surgery. So definitely it would help you rather than reading a whole book. It will give you some ideas from other surgeons also. So also use each opportunity to observe whenever you are in OR, or so even if it is late, even if day is over and last surgery or last therapeutic is going on, there are some incidents when we used to get opportunity to suture therapeutic keratoplasty at the end of the OR at around 11 p.m. And don't hesitate to scrub at any time, to put just 1 or 2 sutures. Otherwise, why to scrub for that? But definitely those 1 or 2 sutures will going to help you. So this is all like from practice PK what we can do. So coming to briefly about introduction, like Edward Zim, as we all know, he performed first successful full thickness keratoplasty in human in 1905 for bilateral alkali burns. He was the first person to perform a solid organ transplant, and PK, as we all know, most successful solid organ transplant in the body. So late Dr. R.E.S. Muthaiya, who started the very first eye bank in India, and the first corneal transplantation was successfully performed in India in 1948, and it was at RIO Chennai. So rather than going in all pre-operative preparations, I'll just take you to OR. These are few points which we need to note before going to OR. I'll be speaking mostly on the OT procedures or what we are doing into the operation theater, just skipping few of the history. So we all should know before taking the patient into operation theater about review of history, and we should review the history or any specific plan which we mentioned in our plan of management. Like there are few cases which needs special attention or which we see on the slit lamp, we just need to note that what we have to do during the surgery. So also slit lamp examination should be performed before taking the patient for surgery, because there are few incidents when patient developed infection or maybe infiltrates in the cornea when patient was posted for optical keratoplasty. So always don't forget to examine the patient on slit lamp before taking the patient for the surgery, rather than having the just torchlight view. So always examine, just go through the investigation what we have done before. And now coming to the operating room, like in operating room, what we have to do, that anesthesia. This is the most important step, I think so, before going to do any surgery. So just be specific about your anesthesia. Like most of the pediatric cases, we do general anesthesia, or almost all. There are few cases who will cooperate around 12-15 years. Then we can just try a block. But definitely, again, while giving the block, it's very important not to have a retrobulbar hemorrhage. I know it's a blind procedure, and it can happen with anyone, but just try to avoid that situation. And if it happens, then don't do the surgery on same day. Try to avoid the surgery on the day or next 2-3 days. We can just reschedule it if it is not an emergency. There are few blocks like O'Brien block, Atkinson block. These all things you all can read in the book more in detail. So this is the one lint block which is showing where the needle and anesthetic solution need to be inserted, and this is the lead block which we used to give after giving the peribulbar block. Sometimes when the lead is moving despite all peribulbar block. Now coming to preoperative preparation regarding the corneal tissue. So always before starting the surgery, check the tissue form. What is written in that tissue form? What is the expiry of that tissue? What is the age of the tissue? And all these things we need to note it down before taking the tissue for the surgery or starting the surgery. And then there is some 60 minutes warming time in which we need to take out that tissue out of the fridge and keep in your operation theater or out of your operation theater. I request you all to respect the tissue. Don't do any mishandling of tissue bottle or anything. This is really painful for any surgeon to see disrespecting the corneal tissue. So now coming to trephines. So before going for surgery, we all should be ready with what trephines we are going to use during the surgery. These are few trephines which we use, like Indo-German and Madhus trephine. These are easily available everywhere, and almost every one of us have tried these trephines when you are doing optical keratoplasty. So there is surgeon by surgeon variability based on comfort of the surgeon. They use different types of trephine. Whenever we are doing optical keratoplasties, we used to prefer these suction trephines. Like in our institute, we used to get these coronate trephines in past, but in recent past, we are not getting that thing. So I think the company or some issue with the availability of these trephines. So what Joja Surgicals has did a good thing. They just copied it, or maybe they just made it some Indian version of this thing with a constant base, and they're just the trephines are really working good in operation theaters, and we all are improving by giving the feedback about the trephine to Joja Surgical. So this is what we used to have. That this is a donor vacuum punch, and this is the recipient vacuum trephine. I'll show you the usage in the coming presentation with the help of some videos. So if you go in detail and see the recipient vacuum trephine, then you can see it can be so this is the part of the trephine, recipient vacuum trephine. This is an outer tube, this is an inner tube, and inside that there is an actual trephine or blade. So what happens in the outer or inner tube, there is some suction which can be developed, and then you can hold the cornea or eyeball with the help of suction trephine and then cut it all around. So this is just a picture of a microscopic picture of the same thing which I try to take in microscope for the presentation. And this is the recipient. This is the marker pin which every trephine used to have. And then coming to suture material, which there are 2-3 suture materials, but we used to prefer nylon suture, like having elasticity of 25% or strength corneal biocompatibility, and it retains tension on the wound as corneal edema resolves. So after this all preparation, when patient comes to your OR, what are our demand? We used to do timeout for the patient to avoid other eye surgery or any mismatch in his bands or anything. So we just need to check when the patient is lying down on the table of the surgery. And then TLC wire route, that is tender loving care, we have to give to all patients as well as our corneal tissues. And one more thing, if you're operating in a new environment, your surgery staff or assistant don't know the procedure. So just give some 5 minutes to train them in brief regarding the procedure. That will really help you to avoid some devastating complications during the surgery. Some sisters or staff are very well experienced for the surgery, but they will be like fumbled when new surgeon comes, or so these all things you just need to calm down, and you have to calm your staff also. You have to counsel them what surgery is going on and what we are doing and for what we are doing. So once they understand these things, the number of mistakes will go down or maybe zero. And then we have to just scrub. So this was just something which we all are praying some or other thing while doing the scrub procedure. So what are the goals of keratoplasty? Like closure without override or underride. Then no posterior wound gap should be there. We have to control the astigmatism and overall curvature, and we have to avoid tissue distortion. Also, prompt redressal of tissue-related complications should be done. So what is ideal suturing technique? Ideal suturing technique will give a stable wound, induce no optical aberration, provide consistent and constant tension throughout the life of suture. It produces no inflammation, and ideally sutures would not have to be removed. If so, it would lead to minimal or change in the wound. So this is just a video clip. I'll just go to the step-by-step procedure of penetrating keratoplasty. First, few people like to mark the suturing points. Like in this procedure, we are marking just 12 o'clock, 6 o'clock, 3 o'clock, and 9 o'clock suture. This was a optical keratoplasty planned in failed graft, and here the surgeon was marking 12, 6, 9, 3. Definitely, it will help. A few surgeons are like they'll mark the center, and or maybe it might be pupil centric, or maybe based on the limbus position they used to mark it. Some don't used to mark this. So this is the marking of suture. First, we have to just mark, and then side ports. Whenever the patient is phakic, or when we are planning any optical keratoplasty, then we just have to make a small side port at your favorable position, which should not overlap the sutures which we are putting later. And then we have to inject intracameral pilocarpine to protect the lens. And then we have to trephine, like we have to trephine it to 0 level. Whatever suction trephines I showed, we have to arrange it to 0 level. Like this is the trephination, sorry. So this is how the suction trephine looks when it is centralized over the pupillary or the area of the center. And then we have to prepare the donor. This is what the donor preparating trephine, which we use. We used to take 0.25 or 0.5 difference from the recipient trephine to prepare the donor. And then after trephining the recipient, we just need to remove the ledge. After trephining it and cutting the recipient cornea, we just need to remove the ledge. This is the procedure, or this is just a small video clip where we are removing the ledge with the help of Vanna's scissor and forceps. So why this ledge comes usually when we enter the anterior chamber obliquely, then the thickness or the length of that ledge is very large. So what we prefer, just enter the anterior chamber at 90 degrees so that the amount of ledge which is forming is very less. And once the ledge is formed, if after cutting the button or after opening the globe, if we are seeing any ledge, then we just need to cut it with the help of Vannas and simple limbs forceps. So just while cutting the ledge, just remember that we just need to hold the ledge near the recipient or host area. So once ledge is removed and all your tissue is prepared by the suction trephines or whatever trephines we are using, suturing techniques, there are 2, 3, 4 suturing techniques which we use. Interrupted suture, which is the most common suturing technique which we use in penetrating keratoplasty, and I'll be talking more about interrupted sutures. And second is a single continuous suture. Third one is a double continuous suture, and last is a combined. It might be combined interrupted and continuous sutures. So interrupted suture, the cardinal suture is the first suture, and the first suture is a Pollack or Bohr's double fixation forceps can be used. Here we can use just a simple limbs forceps with a double tooth inside on inner side, and you can just take the 12 o'clock or first cardinal suture. It should be initiated just behind the fixation, and it can be first suture. It's like never. It can be at 12 o'clock or 6 o'clock based on the surgeon's preference. But usually we used to prefer to put first suture on 12 o'clock position. So this is just a small video clip showing a 12 o'clock suture. So the tissue should be held gently without disrupting much, and then pass through the tissue, and then the recipient should be held with the help of limbs, and then the 12 o'clock suture should be passed. So while taking out the suture from opposite end or from the host end, we just take care that tissue should not be dislodged much. We should be gentle, and we use 3-1-1 knot. Like what our general tendency is to tighten the suture, but we have to remember the goal of the surgery at every point of time. We just need to form the chamber very well, not like something which is a flat suturing. We just need to form the contour of the cornea, and accordingly we have to manage the tension and pressure. So this was the first cardinal suture, which was placed at 12 o'clock position. I'm just showing the video again. Why? Because most of us are practicing in wet lab, and so maybe these videos will help you all. These are all simple video clips which are separated from one big video or maybe many videos. So hopefully it will help you all when you are practicing in wet lab or in any, whenever you're doing any corneal procedure. You can see how gently the surgeon is putting the suture knot and holding the cornea without damaging much, or the damage is almost zero. Then the second suture, I think second suture is also equally your most important suture, and whenever we are aligning the thing. So like this is the second suture which we are passing. So once first suture is passed, we just need to hold the tissue. I'm just holding it in between. And you can see this ridge, which is dividing the corneal tissue into two halves. Once you are sure that you are dividing the cornea into two halves with the help of this ridge, then you can go ahead with putting the second suture. Then from the host, you can just see this, how this, sorry. So you can see this, there are, every limbs has this bites of like two tooths and one tooth. So we used to keep this two tooth part inside, on inside portion to make our holding of tissue easy, whether it is cornea or whether it is host. So this was passing of second suture and how it should be passed. So always remember the formation of the ridge when you are passing the second suture. See, if it is not equally divided, then this ridge will be showing some imbalance, like the cornea on either side of that ridge will not be that equal. So always remember that we have to take care. It should be equally divided. If it is not divided equally, then further suturing will not be that great. I can show you the example in coming slide. So this is how second suture should be passed. So the cardinal suture, this all we all are reading in the book that cardinal suture should form perfect square like this, and two more sutures put 90-degree away from equidistant from the previous two sutures, and ensure that equal tension in all sutures should be there. So it will form a diamond shape pattern in donor cornea like this. So this is one video clip where we can see how the diamond is formed in this, what I was showing in my last slide. So this should be an ideal thing which should be there after passing first four sutures of the penetrating keratoplasty. So this is just a diamond part, and then sometimes what happen, like I told, when we pass sutures, we are not happy with the configuration of the all sutures. Like in this video clip, what we are going to see, even after passing 4 sutures, surgeon was not happy, and always the readjustment of 4 suture can be done. After this happens with many of us. When we pass all 4 sutures, we think that after passing all 4 sutures, we think, or maybe first suture will not look in good, so we cut it, and then we can just readjust the first one. We can readjust the one which is not looking good or not radial or not helping us to forming that perfect square. Then how to hold a needle before, so see, initial days when we are practicing sutures, this is our regular habit, or what we used to do, we used to hold the suture out of the microscope. We used to hold it with needle holder with gloves in our hand. The gloves may be loose, may be tight, and our suture will go inside the gloves, and it may lead to prick and all damage. So what I request you all to hold the needle or hold the suture, everything should be done under microscope, nothing to be done outside the microscope. And when we are holding the suture before passing the next suture, don't come out of the microscope, just be inside the micro, look into the microscope, and whatever adjustment you are making, just make it under the microscope, don't do it outside the microscope. It's very bad habit, and it, what we think, we are very fast in arranging the suture outside it, but actually it is not the truth. So when we start practicing this inside the microscope, it's very easy for all the surgeries. So this is how the needle should be held before the next suture. This is just a small clip. Why I'm showing you, because most of us will do this out of the microscope, but it's very simple if we do under the microscope. So it's just a small clip. We just need to hold it with some limbs or some forceps, and then catch it with the help of needle holder under the microscope. So this is how first 8 sutures need to be passed. I'm just showing it some quick revision kind of thing for all of us. So this is how first 8 sutures should be passed, and after passing first 8 suture, visco should be replaced with the hydro, and we need to check for all leaks. Is it there? Also, we need to check for any override or underride. So this is how first 8 sutures need to be passed. Now burying the knot, there is always oh sorry, the burying the knot, there are always two schools of thought whether to bury it on host side or graft side. It is a big debate. I'll not go into details, but on the host side, when we bury the suture on host side, it reduces the tension on graft host junction at the time of suture removal, and making the risk of wound dehiscence less likely when we bury it on host side. It is being said like that. When we bury it on graft side, it increases the distance between the knot and limbal vessel in order to reduce the risk of suture vascularization and inflammation. So these are all things, or pros and cons of burying the knot and on host side or graft side, which we all need to take into account when we are burying the suture. This is just a video clip showing burying of knot when we are burying the when we are burying the suture on both side. So you can just see how the surgeon is burying the suture. And one more thing you might have noticed, after burying the suture, the surgeon is pulling the suture again. So this is just to change the direction of the suture after suture material which is left after the knot, to make the suture removal easier. So, and then this is like on graft side where the surgeon is burying on graft side. I just showed two videos, and as I told, there are pros and cons of each thing. So you just need to take into account and decide based on your experience or based on the condition where to bury the suture. So these are minor leaks. See, you can see this even after suturing. We just need to check. Oops. Need to check is there any minor leak, and we just need to readjust the suture if there is a leak. Here just surgeon is just checking with the bud, and then you can see the leak from here. Then what the surgeon is doing is just readjusting the suture to avoid that leak. Now you can see the leak is being stopped. So these are all minor readjustment which we need to do after good suturing. Also, sometimes not it will bury from the suture track, so we just need to adjust the position of the knot accordingly so that there will be less or so that there will be no risk, and so that there will be no leak and less risk of complication. So again, this is what even after suturing, we just need to identify which is the loose suture. You can note in this. So loose sutures can be identified during burying also, or you can just note it under the microscope. If you have to be very vigilant, and this is how the loose suture looks. And if it is a loose, then you just need to cut it and just pass a new suture in the same position without passing through the same track. Otherwise, it may lead to leak. So just find something adjacent to the old one and adjust accordingly. So this is just a small clip showing replacing the loose suture. This you can see. So some people used to break it with the needle, or some used to cut it with the vanas. So it's all your choice, whether you want to blunt your needle or whether you want to cut it with the vana scissor. So these few things, like there are few papers which were published, like penetrating keratoplasty from temporal aspect or so. But usually we used to sit superior to the patient unless until the socket is really deep. So these were all video clips which I just wanted to show you. And this I just go briefly through other methods. I never tried much about these techniques, so I never went into detail. So some continuous sutures which we used to put, and some combined sutures like interrupted and continuous also we used to put. But I'll just go through briefly. I think the video clips were good to start with for any starter, good to start with for any surgeon who is starting corneal surgery or who is starting corneal procedure. He or she can practice in wet lab very well, about 20-25 keratoplasties. and then they can go ahead with assisting the surgery to your professors or to your consultants, and then they can just observe keenly through microscope as well as from out of the microscope. I request you all to practice sutures with both of your hands. It will really help you, and then you will not tell that patient's nose is coming in between while suturing. You'll never complain like this when you're practicing sutures with both hands. So these are a few things which, when you are passing single continuous suture, it is torque, anti-torque. These are all physics concepts. So these are torque pattern of single continuous suturing when it is radial, intrastromal, oblique, or overlying sutures. And anti-torque is oblique, intrastromal, and radial overlying sutures. And you can see there is no torque when oblique, intrastromal, and overlying sutures are there. So there are some advantages and disadvantages of single continuous suture. Advantage, it is rapid and easy. Ease of intra suture. Adjustment for astigmatism. There are less chances of vascularization as there is only a single knot. And it is better watertight. Better water tightness is there in single continuous suture. Also, there is a rapid visual rehabilitation and lower astigmatism early post-op compared to combined type. There are a few disadvantages. Obviously, needle blunting will happen and eyes are vulnerable till not time. Any trauma or surgery or infection post-op involving any part of suture needs surgery, and torque forces may lead to late refractive changes, and suture breakage can even happen. Even more, one irregular bite can be unforgiving. So suture breakage intraoperatively, like first quadrant, we have to replace the suture, and if it breaks in third or fourth quadrant, then continue with new sutures and bury two knots and suture adjustment for two different portions. Coming to double continuous suture, first suture should be deep bite like 80 to 90% depth, and second suture should be placed superficially at 50% depth. It gives early optical stability, and first suture should be removed after 2-3 months. And long surgery, it is a long surgery and difficult suture adjustments are there in that surgery. So this is what we used to try: combined continuous and interrupted suture with 10-0 nylon or 11-0 nylon. So radial bites of continuous suture are taken equidistant between the interrupted sutures. So this is just a small video clip showing combined continuous and interrupted suture. You can see interrupted sutures are already being passed, and the surgeon is passing continuous suture. My video is running well, and you all are able to see it uninterrupted.
Yeah, the videos are very nice.
Videos are combination of all consultants as well as fellows of LV Prasad Eye Institute. So I'd like to acknowledge all of them and thank you for all your videos. Few videos are of mine and few are of consultants. So I would like to thank all. Thank you. So this is how the continuous suture is passed. I would like to tell all fellows and all residents that they should practice this kind of suturing also in wet lab. When you're in wet lab, please do practice this kind of suturing also, rather than sitting on patient. So initially, I not practiced this thing in wet lab, but when I started doing PKs, then I went back to wet lab. Never hesitate to go back to wet lab and just practice whatever you want. Just don't sit on the patient and try something new. It's better to have a wet lab thing before this. We have good wet labs everywhere. Request all of you to observe your consultants or whoever is doing the surgery very closely. There are few small things which you need to observe, and when you sit on the surgery, you'll know that you are missing few things which the consultant or surgeon was doing initially. So even though these are video clips I have taken or I just cut it from some big videos, this is all for you and it will definitely help you all. So I request you all to observe very closely. See, after the continuous suturing, the surgeon is tying the knot in the end. So apart from these few important points, I need to just stress on before I finish. Hopefully, I'm not talking too long. I know my attention span is weakest. I'm the weakest student, so I can focus on for 40 minutes or so. So I'll just try to finish in just 2-3 minutes. So few important points are: most prevalent suturing error is tying too tightly. Knot should be always buried. Override of donor tissue at graft host junction is more common than host tissue override, and epithelial rather than endothelial approximation may be more important because far more surface than endothelial problems with misalignment, and astigmatism is a more important problem with surface misalignment. So long-term graft survival, we just need to have preoperative pathology, quality and viability of donor tissue, post-operative events and surgery. So with this, I would like to thank you all for your patient listening. Also, I would like to thank Dr. Praful and DOS as well as Georgia Surgicals for helping me out, and Dr. Praful for giving me this opportunity to speak in DOS Super Tuesdays. So thank you all.
Thank you so much, Sushant. Excellent presentation and wonderful videos. We are really thankful for you to sharing, videos of even our seniors and teachers. Thanks a lot. So, Sharon, ma'am, your comments, please.
I think Dr. Sushank has really shown very, very beautifully through your videos. Congratulations on that. Very nice, very, let's say, meticulously, every small step. And that is what I think very rightly you put it, no matter how much you read from books, there's some things which happen only when you see it practically in a video or your understanding improves. So really kudos on that. A few things that you did highlight, but I'll just go over again. One is, of course, the importance of doing wet lab practice if you have access to it. It doesn't matter what stage in your surgical skill level you are. There's always something to learn or practice or go back to. And if ever any of us find ourselves struggling with a particular step, including, for many of our trainees, a particular suture, a particular direction of suture is sometimes difficult. So, that's what we tell them. Okay, you now understand which is difficult. So go back and repeatedly do that movement. Or as you were saying, use the other hand. Figure out what is wrong. And there is absolutely no shame unless we have that insight and we are honest to ourselves about what we are struggling with. We cannot grow and cannot move forward. So that is very beautifully shown in Dr. Sushank's presentation. One thing which I like to stress for when I'm training or teaching is the way any instrument is inserted or a cannula is inserted into the eye once you have your graft in place. So especially when they are trying to wash out the viscoelastic or just reform the anterior chamber. If you are going in through the graft host junction, then very often they will try to go in horizontally straight with the cannula, and you can detach the Descemet's membrane of the graft with that movement. So a good trick is to go in vertically once you're into the graft host junction, then turn the cannula, and when you see the tip in the AC, then inject. Don't inject blindly, because you can detach the DM even with something so simple. And of course, the depth of your sutures is also important. So when we are passing the sutures, it's a good idea to, as Dr. Shashank was showing in his videos, to hold the graft, pass the needle through, then hold the recipient, pass the needle through. Even if, towards the end, the tendency is to just pass it through without seeing where it's passing, because it's nicely, already partially approximated, but still take the time to make sure that you've got the depth right. But I think other than that, it was so nicely shown through. And if there are any questions, I'm sure any remaining points we can always discuss.
Thank you, Sharon ma'am. So Dr. Anu Malik has gathered questions from many budding ophthalmologists and cornea surgeons. Dr. Anu, over to you for the questions.
Yeah, we have few questions from budding corneal surgeons. Like, what are the most critical factors in donor graft preparation that can influence the outcome of penetrating keratoplasty?
Dr. Shashank, you can answer. Yeah, you're on mute.
Okay. So like donor graft preparation, what everyone is asking, or what it is mostly dependent on what kind of trephines we are using and how we are cutting the tissue, or how we are as I told first, we just need to examine the tissue, what kind of tissue you are putting in, and what kind of what is the age of the tissue, what is the count of the tissue. You just need to check the specular, how is it, and how is the CV, and all these things we need to check. So that is the first and foremost thing, the quality of tissue. Then going ahead, what kind of instrument you're using to cut the donor tissue. Like some places, what initial days, what we used to do, we used to use Madhus trephine. Now also we used to use Madhus trephine, but as we go doing more and more surgery, our hands are more controlled. So when we are doing it in initial stages, when we are punching it, it will just slip from our hand and it will damage our tissue. So what I'll request you all to just practice this step also in wet lab very well before direct jumping into the good quality tissue. As I told you, I really like to respect the tissue. Everyone should respect the tissue because someone is donating it with very warmth and all these things. So we just need to take care of that thing. So just practice it in wet lab. If you are more comfortable with Madhus trephine, then that is fine. But if it is not, I found that suction trephines are much better way of having this better cut of the tissue, and see the kind of inclination it gives. That is also an important. If you are cutting the tissue with oblique trephine, definitely that margins will be oblique and your outcomes will be affected. If you are cutting it very straight with like in suction trephine, which is holding the tissue from behind, and you are cutting it from up, so that will just give you something better outcome thing, or it will just match it with the recipient part very well, and that will just improve your outcome. You can just check all your surgeries, whatever you did in initial days, you are getting too much astigmatism or whatever techniques you're using. This is what one more thing you just need to document what we are using, and while going ahead, how we are changing our style of surgery and how it is improving your outcome. So maybe I may need to do more to tell more. I just like to listen from others. Dr. Sharon or Dr. Anu Malik or Dr. Shefali, please. Your experience.
Dr. Shefali, Dr. Sharon, any comments from your side?
Yeah,
I think Shefali is saying something. Yeah.
if we have access to artificial chamber in our OR, then definitely epithelial side up trephination is better because it will give a very good fit. But if we don't have, like in government setups, many times we don't have, So endothelial, you start with endothelial side up, and then later on you can learn this. And one more point I would like to highlight, that we should always make, as Shashank also mentioned in his talk, we should always make a side port for washing in the end, AC wash, and inserting viscoelastic or washing viscoelastic, everything. So do not try to manipulate so much the graft host junction. That is one point I would like to add. And definitely everyone should go to wet lab whenever you get a chance to go there. So that is the most important thing, because in the government setup we don't have wet labs, especially for the cornea practice. So whenever the OR is free, you go over there and take the tissue from eye bank and practice. Thank you.
Thank you, Dr. Shefali. Dr. Sharon, any?
Yeah, I think they've covered most of the points, but when it comes to the ideal donor, preparation or getting the best out of your donor tissue, one important thing is, of course, assessing the tissue before, as Dr. Shashank was saying. Also, if you're using the manual trephine, sometimes your centration can go, you may not be highly centrated, especially if it's a large graft. This matters, because then if there's a lot of ARPAs, or, it's a really large graft, then you'll get the limbal region and all. So your centration is very, very important. So try to, make sure that you're as center. Both, this is not only, of course, on your donor tissue, but also on the recipient. So centration is very, very important when you're coming. And tissue handling, as he was showing in his video, initially it may be, you're so scared the tissue will slip or something. You hold it very overly tightly with the limbs forceps, and that makes a lot of indentations on the tissue. So you have to hold it, very gently, as was showing in the video, and very smooth movements in the suturing. And that itself, the tissue handling is very important to get the best out of your graft, your donor graft.
So true. Dr. Anu, any other questions we have?
Yeah, we have one more question. Like, what suturing techniques have shown the best outcomes in terms of astigmatism management? And how do we decide which to use?
We'll keep it open to the panel. Yeah.
Okay, so actually, both you can get extremely good astigmatic outcomes with both interrupted sutures and continuous sutures. So if a particular surgeon is comfortable with doing it, it is fine. The point is that at the end of finishing your suturing, as again Dr. Shashank was showing, it is a good idea to titrate your sutures, look for any tight sutures. If you have any form of a keratometer, including the Maloney's, you can use that to check that you don't have any tight sutures or loose sutures, or the rings are fairly uniform. And that is probably a very important step to check how your suturing is at the end of it. So it really doesn't, at least I think most cases, it wouldn't matter. You do get very nice uniform contour with the continuous sutures, but in certain situations, you may not want to do them, especially if it's an eye with a lot of allergy, or a young child where, if the suture breaks early post-op, then you'll be struggling again. So there you may have to think of whether you want to put in a continuous suture, but otherwise, astigmatic outcomes, you can get good outcomes with both, not a problem. So more importantly, you can also choose, as to how many sutures you want to put in. So that's important. Let's say the tendency, or to try and finish a surgery early or faster, don't skimp on the number of sutures that you need to take. If it's an 8 or an 8.5 graft, it's a good idea to take at least 12 or 16 sutures. Make sure if there's an area of leak, as he was showing, then you may have to replace, may go in, put an additional suture or whatever. So do the due diligence. So, yeah.
So true. And especially that video, I wanted to comment, the ledge cutting that Dr. Shashank showed, that is so important.
Very important.
Thank you for sharing it, with
It's the small things, yes. Yeah.
is something that, we are so used to doing. But for beginners, it is very important to see how it is, how to remove that lead so beautifully. Thank you, Dr. Shashank. Excellent videos. We have Dr. Gunjan as well. Dr. Gunjan, are you there with us?
Yeah, hi. Very nice demonstration by Dr. Shashank and all the crisp points that he shared in this video. I was just like to ask the panel, what are your views on doing penetrating keratoplasties in patients of Stevens-Johnson syndrome? Do you want to do them, or you want to just directly go for other procedures for visual rehabilitation like K-Pro, etc.?
SJS, Shefali? Sharon ma'am, she's asking regarding PK in SJS patients.
I think Sharon is.
Yeah.
Yeah. Anyone, please, more than enough. Shefali, you want to say
go ahead.
something?
You should. You should comment on that. I don't have many patients with Stevens-Johnson's. Even
Okay,
we do.
so the thing with Stevens-Johnson's or any patient who has very severe ocular surface disease, be it something as simple as a dry eye, a severe dry eye, to vascularization of the cornea, to how the lids are. So there are so many other factors that you want to keep in mind, and a lot of your decision making would depend on all of this. So it need not be a blanket as to whether it's an SJS or any other condition, but you have to keep in mind all of this. Now, once you have, suppose I'm assuming it's an eye which is a dry surface with some amount of limbal stem cell deficiency, if you can replace at least the limbal, correct the LSCD to an extent, I would still go ahead and do a penetrating keratoplasty. And K-Pro is never our first option for these patients, unless it is such a bad eye bilaterally blind. But still, you would always try with a PK. So in most of these cases, you will go ahead, especially because if it's a very, very dry surface, again, a type 1 K-Pro may not do too well. So, you're already dealing with some difficulty. So it would be better to look at it from what exactly is the problem on the surface and try to correct those, and then do your keratoplasty or if you want to do it at the staged procedure, then you can also, do a PK with a KLAL or a conjunctival, limbal autograft in sections where there is some, panels or symblepharon, something like that. So, but I would still do a PK as primary in most cases, yeah, if required.
First, Gunjan, just like ma'am said, first aim would be to stabilize the surface, take care of if there's any activity and all, we have to take care of that, the limbus, the inflammation. Then, step by step, we go ahead. And of course, we keep K-Pro for the end. That to the type of K-Pro, it depends whether the eye is wet or it's a bone dry eye. And doing K-Pro is one thing, but managing the complications during the surgery and even after the follow-up, that is very important. So I think it's better.
Very true, Aditi. And for these things and with all grafts, I think one thing which is very, very important and is the counseling which goes into it, not just of the surgery, but the need for the post-operative follow-ups, the care, the medications, because very often they are, for many patients, it's like they're tuned to cataract surgery.
Yes.
So it's a one-day thing, you're done, and then maybe one more checkup or two more checkups in their head. And no matter what they agree to before the surgery, 3 months down the line, they have forgotten all about it, especially if the graft is clear and they're doing well.
Yes.
And then they'll come back a year later with a rejection. So, and it's very tragic. So that counseling is essential for anyone who wants to do any form of transplants, and all the more if you're planning anything on a surface, ocular surface disease. So as important.
Thank you so much. I think we are on time. I would like to thank again our speaker, our esteemed panel. Thank you, Dr. Sharon, Dr. Shefali, Dr. Anu. Thank you, Gunjan, for the lovely question. And I would like to thank again DOS, the organizing committee, Dr. Prafulla Maharana, and the whole executive team, our president, our treasurer. Thank you so much for this opportunity, and we'll be back again very soon. Thank you so much.
Thank you, Aditi, for a wonderful
Thank you.
moderation.
Thank you.
Thanks a lot.
Thank you, everyone.